from the Washington, D.C. area. It's the Inside Scoop, all the news that our viewers want to know. Now, here's the host.
Welcome to Inside Scoop Virginia. I'm Bettina Lawton, and I'm your host. And tonight we're going to be talking about a topic that has been in the news a lot in Fairfax County over the last actually couple of years, but especially this year since January. We've had a number of our children in high school who decided that they were going to commit suicide, and they did. They died by suicide. And it's a bigger problem than that, and we're going to talk with some folks tonight that can shed some clarity on this and educate us about this. It doesn't need to be sensationalized. It's sensational enough. So we're going to talk about the facts and the causes and the research, and we have people with us tonight from the American Foundation for Suicide Prevention. It is a national nonprofit. It is devoted exclusively to enhancing the understanding and preventing of suicide through research and education and advocacy and reaching out to people with mental disorders and those who have been impacted by suicide. And we are going to talk about the work that they do and what they have found. The organization was founded in 1987, so it's not a newbie to the field. And it was founded by scientists and concerned citizens and people who have survived, have been survivors of suicide incidents. They have a national office is in New York City. They have 67 chapters around the country. And I'm very pleased that we have with us Ryan Newcomb. He is the area director for the Metro DC and Virginia, the National Capital Area, and we also have with us Vicki Johnson, who is a member of their board of directors and the board chair. So welcome both of you to Inside Scoop Virginia.
Thank you for having us.
Appreciate you coming out to do that. And the very first thing I want to find out is how you got involved with this organization. Vicki, why don't you go first?
I got involved 3 years ago. I lost my husband to suicide 3 years ago, May 25th. It'll be 3 years. And a friend of mine who had actually lost a cousin suggested that I do a community walk that AFSP was putting on, and that I might find some comfort through all of the pain and grief that I felt. And got involved with them then, and have found that they've provided tremendous support, encouragement. In some ways, it's very helpful to be with a group of individuals, all who have either suffered from a loss by suicide or who suffer some type of mental health disorder, and that it's been very comforting to be a part of that.
Okay. Well, I think we actually have a clip for Ryan that I want to show if we're ready to do that, because he has a clip for something that he's done with NBC4, so let's roll it.
My name is Ryan Newcomb, and I suffer from depression. I just remember being completely overwhelmed. I remember being sad for no reason all the time. I think being gay just happens to impact even harder, if you will, the depression or mental illness that you might live with. The coming out process is incredibly difficult. Growing up in the South, it was even more difficult. And so that was all internalized for me, along with the depression and anxiety that I was struggling with. I would say that it's okay to seek help. It's not a sign of weakness, it's a sign of strength.
Very nice. So congratulations.
Yeah, it was a great opportunity to be able to share your own story and the help that you might help other people maybe.
So how did you get actually involved with the American Foundation for Suicide Prevention?
Well, in a professional role, but it was through my own struggles throughout, since I was young, that I took on this role. I'd been working in the nonprofit field for a while, but this has truly been 2 years in one of the best experiences I've had professionally, working with people like Vicki and our other board members, people who have lost their loved ones, people who struggle themselves, people who are willing to courageously stand up and take a message out that's not always easy to share, but that is so necessary today to share.
Well, I'd like to get us some information on understanding suicide. So the Center for Disease Control said that the incidence of suicide went down for about 10 years, from 1990 to about 2000, and then it started going back up again. So where do we stand? How many people are we actually losing to suicide every year?
Well, the statistics as we know them, and I do say as we know them, are 38,000, about 38,000 people a year die by suicide. And I say as we know them because of the lack of funding for the National Violent Death Reporting System and other areas don't give us the full scope, the picture of this, really what's an epidemic in our country. It's one of the top 10 leading causes of death in America. And most people don't realize that. And especially when people lose their loved ones, it's a very different type of grief. One of the things we try to do as AFSP is to let people know they're not alone, and this is a leading cause of death in America. And we hope that we're breaking the stigma so that, one, people can get help. And know that it's okay to get help. But two, that when they have experienced a loss, that they can share that with other people and talk about it and not be avoided. We've had people that have lost loved ones, and people would avoid them in the community afterwards.
Wow.
Just because they didn't want to address it, the uncomfortable reality.
Well, and how does one address it? I mean, Vicki, when it happened, because you experienced this, is this something where it's simply having someone say, I'm sorry to hear about your loss, that's sufficient? Or what would you advise people who because obviously in this community, a lot of people have been affected by the deaths that we've had.
Very good question, because there is such a stigma still. People, the range of emotion that people have about suicide can range all the way from being very angry that this individual clearly was selfish enough to take their own life to, feeling embarrassed by the entire thing. And the reality is that depression and mental illness is a physical ailment very similar to any other ailment like heart disease or cancer or anything of that nature. And until we really get the word out that that's the case, we can't get past the stigma. Right. So when I first, I think about a month after Paul took his life, I went to a social event in an industry that I belonged to where there were thousands of people, and I got the gamut of people who really didn't know what to say to me. I sort of talk about the fact that I felt like I was in a room with 3,000 people and I was naked.
Oh. Right.
Because it was just so obvious the discomfort that people felt. And I give people the advice now that they should let people off the hook a little bit, because people are uncomfortable. They don't know what to say. And so if you can stop them immediately and say, it's okay. There's nothing good to say about this. I don't have anything good to say about it either. And leave it at that, then that provides a comfort zone where you can move on with your conversation without sort of feeling like you have to have this very uncomfortable silence.
Okay. Well, is there a split between the number of women versus men, or male versus female, who die by suicide?
Yeah, it's a very interesting statistic because I think 4 or 5 times as many women actually attempt suicide as men, but men complete suicide at a much, much higher rate than women do. And that can be for many reasons, and that's some of the reasons we're trying to do the research we fund as the largest private funder of suicide prevention research, is to get to the key and the core of what takes someone to this place in their life where they, whether it's a 15-minute window or whatnot, that they would choose to make such a decision.
It's typically higher in men, because men tend to use firearms,
Okay.
Which tend to be much more produce much more death than an overdose or by other poisoned means, which tend to be more what women use. Those figures that 4 times as many men who have successful rates of suicide are increasing in women as we see women use more firearms as well.
Okay. So now what about the age? Is there a difference in the age? Because we see it, of course, here because these are teenagers. Is it suicide mostly a teenage phenomenon?
Well, it's not, but and in the largest group where it does occur is middle-aged men at the moment. Oh. But it's the 3rd leading cause of death for 15 to 24-year-olds where that is concerned. So while you have a difference in numbers, it is the 3rd leading cause of death in that age demographic. So it's really important that we educate our kids that it's okay to get help and provide them the proper means and ability to do so.
Well, that's shocking. I didn't know that. And I have children, my boys are now in their 20s, but I remember when they were teenagers, I didn't talk to them about suicide. I talked to them about driving the car. I talked to them about those kinds of safety things. But it would not have occurred to me. I had no idea that it was that high.
We still don't talk about it enough with our kids. And I think that the more that we can bring it out within the school districts, the more that we can speak about it at home and ask the really tough questions. Are you sad? Are you feeling as if you would hurt yourself? Those types of questions. Then we will open that conversation up much more.
I think, too, one of the things we have to do as a society is to realize that the brain is no different than any other part of the body, and that mental illness is a physical ailment, as Vicki said, and that a person who dies or suffers from heart disease or kidney disease or liver failure is suffering from an illness in the exact same way that someone suffering from depression or anxiety is suffering from an illness that is treatable. And so I think we need to look at it through that lens and make sure that people know that it's okay to get help.
Well, that's I think the critical thing, and we have been trying to get that message out back from when Tipper Gore was doing it, and that was probably before you were able to read. So it's been that long, it's discouraging. Anyway, we are going to take a break. We will be back. Stay with us.
I need a job.
Necesito trabajo.
I would like to speak English better.
Me gustaría hablar inglés mejor.
I want to be a U.S. citizen.
Quisiera ser ciudadano de los Estados Unidos.
For over 35 years,
Por más de 35 años,
the Hispanic Committee of Virginia has been serving our community.
el Comité Hispano de Virginia ha estado sirviendo a nuestra comunidad.
Job training and placement,
Capacitación, ayuda para conseguir trabajo,
education for children and adults,
educación para niños y adultos,
immigration, naturalization, and medical referrals.
ayuda para los procesos de inmigración y naturalización y orientación sobre médicos
Are a small part of what we do.
son solo una pequeña parte de lo que hacemos.
For help, information, or to volunteer,
Para ayuda, información o para ofrecerse como voluntario,
contact the Hispanic Committee of Virginia,
comuníquese con el Comité Hispano de Virginia,
helping everyone participate more fully in American society.
ayudando a todos a participar plenamente en la sociedad norteamericana.
Hey, Lena, where's yours?
Would you notice if you were missing half your kidney function? According to the National Kidney Foundation, 20 million people have chronic kidney disease, and 20 million more may be at risk and not even know it. Anyone with high blood pressure, diabetes, or family history of chronic kidney disease is at risk. Early diagnosis is vitally important. To get the whole story, talk to your doctor and visit the National Kidney Foundation at kidney.org or call for a free brochure. Because when it comes to chronic kidney disease, you might not know the half.
We're back to the Inside Scoop.
Thank you.
And again, your
Perfect.
host.
Saving for...
Welcome back. I'm Bettina Lawton. This is Inside Scoop Virginia, and we are here tonight talking about suicide prevention. And we have as our guest right now Ryan Newcomb. He is the area director for Metro DC and Maryland of the American Federation for Suicide Prevention. I never am sure, is it suicide prevention or prevention of suicide? And Vicki Johnson, she is the board chair for the National Capital Area. And when we left, we were talking about differences in demographics and age and things like that. I think the only one that we haven't sort of talked about, too, that we haven't talked about is there a difference in who dies by suicide by race or geographical area? I mean, we've said, yes, there is for female males and age, but what about those kinds of areas? Are people on the East Coast more in danger than the West, or what?
Right. I think what I would say to that is that mental illness does not discriminate, first of all.
Right.
It knows no age, it knows no sex, sexuality, race, but at the same time,
this guy's in the middle.
Some of those at higher risk include the LGBT community, the Native American community, and many others.
Okay, so there is some differences, but it's sort of expected. And the East versus West, how does that work? Although you've said guns were a big deal, I would think people in the West would be at higher risk.
It's an issue of means there. It's an issue of lacked proper treatment, being rural, more isolated, lack of access, if you will, and so then it's the higher rate of gun ownership there, and so as an organization we don't take a position on the Second Amendment, but we encourage gun safety, and it's crucial that those in crisis or those that are truly struggling with mental illness have the most lethal means removed from their reach, really, whether it's through their loved ones or their friends or anyone who can just ask them, and that's another thing. I think people think that if they ask someone about if they're going to take their life, or you thinking about suicide, that it's going to plant the idea in their head, and that's just not the case. Research has proven that it actually gives them an opportunity to talk about it, to acknowledge it, and to realize it, and maybe save their life. So
there has been some strong research that does suggest that in other countries, when you take away some of the risk factors, you lower the amount of suicide and the volume of suicide that does take place. So in other countries, when they've done, bridge safety, structures across bridges, when you've done things to put safety things in the medication so that you can't open up medication quite as easily, that type of thing, then that you really do greatly reduce the number of suicides that take place. So that is, something that, from a research perspective, we have been able to see in other countries.
Well, what other risks are there that people should be aware of for purposes of suicide?
Well, the first thing that I would suggest to everybody is that just because you have a mental illness does not necessarily mean that you will show suicidal behavior. But some of the major risk factors are obviously depression, schizophrenia, conduct disorder, which obviously happens in children more frequently, and anxiety disorders, that type of thing. If you've had a previous attempt of suicide, then that's clearly a factor that can be a problem, or you've got a serious medical condition. So those are some of the major risk factors that can tend to increase, your chances of thinking of suicide, or at least having that as a factor.
Now, can the tendency towards suicide be inherited? Does it run in families? There are a lot of medical conditions seem to run in families. Does suicide run in families?
Suicide doesn't necessarily, I don't want to say that suicide runs in families. If you have mental illness, it can be genetic. So you can have, if you have someone who suffers from depression or bipolar or schizophrenia, then it tends to run in families. It doesn't mean that everyone in the family will either have a mental illness and or contemplate or attempt suicide. It does mean that it is a risk factor that makes it higher that you need to be aware of. And that scares a lot of people to understand that that really is something that you do need to be much more aware of. And so you do see suicide more frequently in certain families where we have gatherings where people unfortunately have lost a good number of individuals within their family, uncles, cousins, sons, and daughters. But again, it's not a direct correlation.
Okay. So are there sort of environmental factors, which I sort of, how you get raised, that nature-nurture kind of discussion, but also whether there are environmental factors, like if you live near chemical plants or if you're, you know, those kinds of things. Is there any research on that kind of stuff?
What I would say is that that's what we're doing the research for. You know, we know that a myriad of things can lead to someone being suicidal or taking their life. It could be environmental, it could be socioeconomical, it could be a cultural factor, it could be a situational factor, and it can be genetic, like Vicki mentioned. It could, and then the more of those things that you have together, the higher risk, the more likely there's to be severe mental illness. You asked earlier about differences between races. The highest group in America that for suicide is the Native American population, and you see so many of those different factors pulled together: poverty, you know, histories of drug and alcohol abuse. You know, so many of these different things that come together to make that storm, if you will.
I think the easiest way to describe it is this. People who have some of those risk factors are more vulnerable to having environmental factors play a role in their thoughts of suicide. So if we take it to a personal level, my husband, who is a very well-known, very well-respected architect in the Washington area, Washington, D.C. area, he suffered from depression. He had depression run in his family. It was because of job loss, job change, not feeling good about himself, and some environmental factors that I think and believe strongly pushed him to the point where he felt hopeless and he felt like there was no way out and that he was of no value to anyone else. So yes, those environmental factors can be financial, or a stressful relationship or marriage, or loss of a job, or, you know, access to lots of drugs and or firearms. So it's those types of things, but it's typically most individuals already have a depressive state or a mental health disorder where those environmental factors that you and I might otherwise be able to roll with, they can't roll with.
Well, what do you look for in terms of signs of suicides, warning signs? Because every time we have this happen in our schools, people say, oh, I had no idea. I mean, what do we need to look for? I mean, I actually had a friend the other day who's in a lot of pain because of some illnesses say something about, boy, you know, a couple of pills and it'll all be over. And sort of the warning bells went off, but I've never had anybody say that to me before. So what should people be looking for?
Well, I want Vicki to answer that. But I would say too, though, that 90%, we have to remember, no matter what she lists, that 90% of people who die by suicide have a treatable mental illness. It doesn't mean it's being treated, but it's, you know, that's key, so that we understand that getting treatment and help can be the prevention. But I'll defer to Vicki on that.
I think you bring up a really good point about your friend, because most people actually tell someone that they're thinking of taking their life. And so they'll talk about it. You'll see some major changes, perhaps, and especially in kids, I think we need to be aware of some of the major things that happen that change. They either sleep a lot, they lose their active role with their peer group, and so they tend to sort of withdraw. Their grades change dramatically. They, are feeling humiliated or bullied at school, which is huge. They have a lot of anxiety and have anxiety attacks, that type of thing. So when you start to see for any longer than a week or two some really big behavioral changes, loss of appetite, or for that matter, huge increase in appetite, perhaps in a bipolar situation, you see them very, very high strung, as if they're taking all sorts of risk, and very, feeling as if they're speaking quickly and can do all sorts of things, and then followed by a real depressive state. So I think we just need to really key in on some of those things that are different from your normal, typical, natural being, and look at those. And again, most people will tell you that they're looking at taking their life, they're looking at hurting themselves.
Wow.
They confide with someone.
So what are you supposed to do? I mean, if you get this sense that there is such a huge sense of shame and a huge denial that goes on, and there are limited community resources, at least in Virginia, what do you say to somebody?
Well, and I'll let Ryan help with this, but I think one of the things that we need to do is we need to be honest with that individual. We need to ask them, are you thinking of hurting yourself? Are you thinking of taking your life? What can we take you and get help? Can we make an appointment for you? In many cases, someone who is in that position doesn't feel as if there is any help. Right. And so if you can help assist them and even go with them and get them some professional assistance, whether it be counseling and or medication or both.
I would go back to the means restriction for someone like that, making sure that the most lethal means especially are not within their reach, and talking to them about the importance of that. Take them to a walk-in clinic, take them to the emergency room if it's that serious. There's the National Suicide Prevention Lifeline. It's 24 hours a day, 7 days a week, and you can have them call that.
Do you have the number real quick before we go to break?
Sure, it's 1-800-273-TALK. So 1-800-273-TALK.
All right, well, good. Well, that's a resource that people can use if they have someone they think is potentially going to die by suicide. Stay with us. We're going to be back.
Saving for retirement might be easy for some folk, but for others, it might take a little more work. And for those who haven't started, there are still things you can do to catch up.
Oh, that is good news.
Like getting out from underneath past debt. And don't get wrapped up with high-interest credit cards.
Get you some eyes.
Be diversified with your investments. Don't put all your eggs in one basket. Your financial goals are not out of reach. The choice is clear. For a happy ending, choose to save.
Everyone with alcohol and drug addiction is in the same boat. With treatment, you can find solid ground. For drug and alcohol information and treatment referral for you or someone you know, call 1-800-662-HELP.
Dude, are you sure you want this tattoo? Because just do it.
Some mistakes in life are permanent. Like hearing loss. To learn how to protect your hearing, visit ASHA.org.
You've probably heard about heart disease, but did you know that it's the #1 killer of women nationwide? Heart disease claims more lives each year than breast cancer, lung cancer, or strokes combined. But there are steps you can take to protect yourself against it. For more information on how you can prevent heart disease, contact your local American Heart Association or visit their website at www.americanheart.org.
We're back to the Inside Scoop. Here again, your host.
Welcome back. I'm Bettina Lawton. This is Inside Scoop Virginia, and we are talking tonight about suicide, the prevention of suicide, how you can recognize it, how you can help people so that it doesn't actually happen. And we have switched out guests. We still have Ryan with us, and as you know, because you met Ryan for the prior two segments, he is the area director for the Metro DC and Maryland area. And joining us for this segment is Dr. Julie Verthaler. She is the Director of Clinical Training, Clinical Psychology Department, the Chicago School of Professional Psychology in DC. That is a mouthful.
Yes.
And I appreciate you coming because we talked a little bit about what some of the suicide issues and some of the mental health issues, but I want to talk a little bit more about that because there's plain old depression, as I tend to call it, which doesn't have all the sort of the sexy bells and whistles that like bipolar has and all this other stuff. But is it what kind of mental illness? When we say mental illness, 90% of the people are suffering from mental illness. What do we mean? Is it just using that in quotations, regular old depression, or do most of the people have one of these more severe sort of psychotic breaks or bipolar or these other kinds of things that people hear about? But most of us know folks with depression, but may not know anybody with these other types of illnesses.
Right, and so a lot of times when you come into treatment, one of the first things that we do as psychologists or psychiatrists is really look at a diagnosis. But a lot of the symptoms really go across the span. So people that have been suffering with depression might have bipolar disorder, but it's never been diagnosed before. A lot of times the depression will come first, and so maybe years later the mania or the bipolar will come out. There's also all kinds of other mental illnesses that you have suicidal ideation with. You can have schizophrenia, bipolar, personality disorders. I don't know the exact statistics on it, but I think of the main disorder that is probably most successful with suicide tends to be bipolar disorder, actually.
Oh, really?
And people with bipolar disorder actually have very, very severe depressive episodes that when they kind of come out of the mania, it's very hard. It's difficult to treat, but it's very treatable. So we do try to come to a good diagnosis, but we also really try to look specifically at symptoms. And because they overlap a lot, we then look at those symptoms to look at what treatments are best for them, what medications are best for them, what therapies might be most helpful for them.
So, well, let's talk about that. I mean, what if you get diagnosed with these types of depressive or mental health issues? Is there a standard treatment? I mean, I hear people say, oh, that talk stuff, we don't need to do the talk stuff, just give me the drugs, give me the drugs. But other people say, no, you don't, you know, it's one or the other, it's a combination of both. I mean, does it depend on what they've been diagnosed with, or how does that all work?
Go ahead.
Well, I was just going to say, in my own personal experience, I for so long I was just taking medicine. You know, I was just taking medicinal treatment, and didn't realize that for someone suffering just from chronic depression or major depression or depression in general, that along with that, to do cognitive behavioral therapy or some type of therapy or any type of talk therapy can be, along with medicinal treatment, is the most successful rate of success from getting out from under the depression or whatnot that you're experiencing. I'll let Julie, as the mental health professional, speak more to the other disorders and different type of diagnoses. But as someone who has lived through it a little bit, you know, I really think that it's important that people who just take medicine realize what therapy can do for them as well, or vice versa.
And overwhelmingly, research really does show what Ryan is saying, that the combination of medication and therapy is the most successful. It does create the longest term benefit for people as well. There are people that for various reasons don't want to go on medication or they don't want to do therapy, so they kind of start in one area. But typically providers really try to encourage them to do both. There's cognitive behavioral therapy is the probably most researched therapy.
So what is that?
So cognitive behavioral therapy really looks at how your thoughts, your feelings, and behaviors all kind of play off of each other. So for example, when somebody is very depressed, they might have thoughts of being very worthless. They might think, you know, I have no future, I'm a complete failure. This continually goes through their minds. So this leads to feelings of just sadness, depression, just feeling really down on themselves. And then they start behaving in different ways that kind of keep that cycle going. So cognitive behavioral therapy really looks at breaking some of those leaks, breaking some of those thoughts, replacing them with more rational thoughts. You know, there's typically some homework or stuff involved with the therapy.
Oh, really?
In terms of, you know, going home, kind of writing out different thoughts that you might have, coming up with more rational ones. So if you're thinking, you know, I have no future, my whole life has been a failure, thinking about times when you were successful. What is the reality of what's going on? Because the depression can really kind of jade those thoughts into a certain way and you get stuck there. Right. So the therapy really tries to work through that. There's the behavioral piece too. I mean, what we know is trying to bring in more positive behaviors into somebody's life, working with their sleep pattern, adding exercise, which can be difficult for somebody when they're really down to have the motivation to do that. But if we can start increasing those behaviors, the more you do something, more like you're continuing to do those things. And so really promoting just a healthy lifestyle in general. I have people all the time, you know, they start exercising or running and they're like, this is what saved me. More than the therapy, more than the medication, but you know, so working with their treatment providers to encourage them and help them figure out ways to start those behaviors when they're not doing that is very helpful.
So this does not sound like the sort of classic television therapy, lay on the couch and talk about how terrible your mother was when you were 4. This sounds to be much more proactive kind of, this is where you are today. Let's see about getting you in a different place tomorrow.
Right, and that's really the CBT or cognitive behavioral approach. There are still therapies that do kind of the classic, what we would call psychodynamic therapy, that looks a lot at your childhood, where you came from, and those can be, there's research that shows those are very beneficial too. Some of the research really shows that the cognitive behavioral piece is very, very good, particularly in the initial stages, to get somebody activated and back on their feet and proactive in their lives. But it's very goal-oriented. It's, you know, therapists will create specific goals with the person. You know, you know, if you're having trouble getting out of bed, 5 days a week, we're going to get you out of bed at a certain time, and start, you know, promoting those behaviors so you start doing it on a regular basis.
So, and you're reversing the negative behavior and the negative thought process. It's amazing, you know, for me, you know, getting out and running 15 or 20 miles a week, before when I didn't barely at all, has just been the best thing for me. And but it's so many factors too. It's working together to make sure everyone's different.
Right. So. Now, how does it work? Because we had an adult. We've talked about children, but an adult in the area that many of us know, who killed himself with a firearm about 2 or 3 weeks ago. And there's been a lot of chatter that he was on some kind of medication, and that's what sort of pushed him over. How real are those side effects? Because you see in the papers, somebody will commit some horrible crime and they'll say, oh, it was this drug that I was on for my depression or my anxiety. Is that really common? I mean, I'm sure that it's a lot of side effects never ever happen, but it's you know, people are talking a lot about it in this area. Is that something that
That's actually very rare. It's a warning label that they have on the medications because they found a certain, you know, percentage they have to report that. But that's very rare. I mean, we do you know, talk with people about when they start on a medication, really monitoring it, having family involved, meeting. You know, they should meet with their psychiatrist once a week in the beginning to really watch those side effects, see what's going on, constantly kind of doing the risk assessments to see where they're at. But the actual side effect of, suicidal ideation increasing from medication is actually very small. Okay. It's a very small percentage, but I think people kind of grasp onto that as something to kind of run with. I don't know if you know much about it.
Well, I mean, I would just say that as far as that's concerned, there is the black box concern, but that you need to work with the provider to make sure the medication is correct. And that is an adjustment period in itself for many and most people. Finding there's different types of medication that work in different ways and different brain chemicals and that might be lacking. And so that's again goes back to the point of the, this being a medical condition like any other.
Right, so you really have to have a good doctor, you've got to have a lot of trust in them and actually follow it. You don't skip the appointments and do things like that. It's got to get monitored. And I would ask you about, there's one that I read about recently that I was like, wow, and that's, I don't know what its exact title is, it's the electroshock concept, that was coming back in vogue. Is that really true?
So it's actually been there all along, and it's typically used, it's actually been found to be much more safe than what we originally thought, and it's very different than what you see in the movies like One Flew Over the Cuckoo's Nest, where they're having this big convulsion and stuff. But they found it to be extremely effective, and particularly in very severe cases of depression, mania, things like that. But it's typically used as if somebody's been on medication and in therapy for a while, if that's not being very effective, then they'll consider this. But it's not used very frequently.
It's last resort.
It is. It's kind of a last resort. There can be side effects to that are can be stronger than some of the medications.
Because this is actual electrical currents into your brain or something?
Right, and an anesthesiologist is involved that kind of sedates you, and they put electric currents through your brains, and it alters the brain chemistry. It's actually a very quick treatment. It can pull somebody out of a very severe depressive episode very quickly, which is a benefit if you're really concerned that somebody's very severe and you're really concerned about something and we need to get them out of it quickly. One of the things with medication that's always important to remember is that it does take time, and that can be really, particularly when you bring a therapist in, is where it can be very helpful for them to be meeting regularly with their therapist during that time, because it can take on average 4 to 6 weeks to know if one medication is going to work for somebody for depression. And so at that point they might try a different medication. So it can be a process of a few months before you found the medication that is right for that person, they're tolerating the side effects, and the psychiatrist has decided this is the right.
Are there mental health facilities that people can go to in this area? I know Ryan gave us an 800 number that people could call, but are there specific mental health facilities that people should be going to?
Ryan might go
Absolutely, and if they want to be in touch with us, we have mental health professionals that we can refer them to, like Julie and others that are in the area too, that work on the grounds and the grassroots level.
All right, well, we're going to be right back with a whole new set of guests, so stay with us. We'll be back.
Art, a universal language, an expression of culture, of self. And now, thanks to Empowered Women International, a way for emerging and established immigrant and refugee artists and artisans to find hope to earn a living while enriching the lives of all of us. Empowered Women International, making a better America every day. For more information on Empowered Women International's educational programs, or to make a tax-free donation, contact cfrip at AOL.com.
You'd think it would be easy to tell which kids have trouble with their eyesight. But that's not always the case. Even though 1 in 4 children may have a vision problem, eye doctors tell us the symptoms aren't always so obvious. We do know that 80% of all childhood learning is visual. And without good vision, kids can have trouble learning to read and may fall behind in school. For clues on how to spot the real-life signs of childhood vision problems and what parents can do, visit checkyearly.com. A public service message from the Vision Council of America, and reading is fundamental.
We're back to the Inside Scoop. Here again, your host.
Welcome back. I'm Bettina Lawton. This is Inside Scoop Virginia, and we are talking about suicide prevention. We've covered a lot of ground. Today we are in May, and May is Mental Health Awareness Month, I think. So this is a good time for everybody to think about it and make sure that they're all together. So we're going to turn this last segment to talk about schools and high school type aged kids. As we heard earlier in the show, it's the 3rd leading cause of death for kids in their teen years, and we certainly have had a lot of that this year with 4 young adults this year who have died by suicide. And so I want to welcome 2 new folks to our guest. Maureen Iselin is a board member for the National Capital Area of the Foundation for Suicide Prevention of Suicide. I can never get it straight. And Joy Lesnick is also a member of the Foundation for Suicide Prevention. So tell me how you got involved in the foundation.
Sure. I actually got involved back, I lost a cousin to suicide back in 2005. And following his death, my dad actually got involved in some of the community walks. He helped organize a community walk in Fairfax, and then he actually spearheaded starting the local chapter. So I've been with them since the chapter began back in July of 2010.
Okay.
And I also joined as the result of a personal experience. My brother died by suicide at the age of 14. He was in 9th grade in 2001, and the first chance I had to do something to remember him was in 2009 in Chicago at one of the AFSP overnight walks. And when I moved to Washington, D.C., I found that it's been really healing for me to work towards suicide prevention and to also especially work with high school students about recognizing the signs of depression in this More Than Sad program that we're talking to you about today.
Well, you both mentioned this walk. So are there walks that people can participate in? Do they?
There are. So every year, AFSP National up in New York has an overnight walk, and that happens every June. But in addition, each of the local communities throughout the United States have community walks every fall.
Okay.
So this year we'll have our Fairfax walk, which will take place on September 7th at Fairfax Corner. And then we have our DC walk, which will take place September 20th on the National Mall.
And how long are these walks?
So the community walks are 3 to 5 miles.
Okay.
And I encourage, even if you don't think you can do the walk, at least come for the opening and closing ceremonies. You're surrounded by people that have not only lost somebody but are struggling themselves, and it's just a very inspirational and uplifting event, and it's really important to get out in the community and kind of bring awareness. So I encourage you to, they're called the Out of the Darkness walks. If you go to outofthedarkness.org, you can find out more information.
Okay, well, good. That sounds like a good thing then. So let's talk about the schools. There's a couple of different programs that are available at the high school. I guess it's high school level. Do you do middle schools, or is it mostly high schools?
The 2 videos are aimed towards, there are 2 films that are part of the More Than Sad series. One is More Than Sad Teen Depression, and one is More Than Sad Suicide Prevention Education for Teachers and Other School Personnel. And they're really aimed at students age 14 to 18, so really the high school age.
Okay, and so what do these films do? What do they tell these? What's the whole message? That there's help, or you're not alone, or what's the central theme here?
Yeah, well, both of those things, exactly. Okay. And the More Than Sad Teen Depression educates teens to recognize the signs and symptoms both in themselves and in their friends. So there's a series of 4 vignettes in which 4 different student stories are presented, and it looks very different. Many teens and adults think they know what depression looks like, but really it ends up looking very different in different people, and identifying what those different signs and symptoms are in yourself and in others. And it also models ways to get help. So each of them finds help through a different supportive adult or supportive school personnel or teacher or parent, and it really models how treatment can take place. It sort of takes away some of the scariness of that and takes away some of the stigma about getting help and what that help can achieve.
It's really about starting the conversation amongst high schoolers, because I think a lot of times high schoolers, they'll maybe tell their friends something that they wouldn't necessarily tell an adult.
Right.
So being able to make sure that everyone, kind of knows what to look out for, so that if they do recognize something in a peer or a friend or just another classmate, that they can recognize it and get them help and reach out to an adult then. So.
Well, is there a lot of concern, I mean, among teenagers, I would think if they realize that a friend was having sort of suicidal thoughts, I mean, reporting that, makes it real. Is there a reluctance? Do you need to overcome that kind of attitude amongst folks at that age?
There's definitely a reluctance. You don't want to, be the person that's ratting out your friend.
Yeah.
So it is kind of trying to let them know that it's okay, and you'd rather have your friend mad at you than not have your friend around anymore, and that there are ways that you can anonymously can call one of the crisis line, crisis link in our area, and talk with somebody and get advice as to what you should do if you're concerned about a friend, and you can have your friend call that number, so that there's not kind of the getting them in trouble type feelings, which I think is important for teenagers, because they don't want to be the uncool kid who got somebody else in trouble.
Exactly.
In April, we gave this presentation to more than 2,500 students at T.C. Williams High School. Volunteers from the AFSP showed the video and also led the discussion along with their support personnel, their guidance counselors, their teachers, their school nurse, their mental health professionals. And really, by opening up that conversation, I remember one of the school counselors opened up by saying there's a difference between snitching and there's a difference between telling, and just really putting that out there and having the conversation with the students to know that this is a really important thing, that when you're helping your friend, you're not snitching on them. So really having that conversation with students really, I think, can help make a difference.
Well, and how long is the program? Is this like an hour? Do you do it after school? How does this work?
It's about an hour-long presentation. It can be an hour to hour and a half long. The video is just about 30 minutes long, and so there's a little discussion ahead of time, show the video, and then have a little discussion afterwards. The DVD really helps facilitate the conversation, and there's also a DVD that can be shown to teachers and parents and school personnel. The AFSP, the National Capital Area Chapter, can provide these DVDs free of charge to any school district, any after-school program, to any scout troop, youth group, anyone who's interested in having this, and we're happy to volunteer to help facilitate the conversation if the group is interested. So this is a resource that's available.
Well, wouldn't it make a lot of sense to have you all come in to facilitate it? I mean, I would think most people are not really knowledgeable in this area. I'd be a little reluctant to have my kid in the scout troop or something get shown this without somebody who actually knows what they're talking about.
Yeah, sometimes, like with T.C. Williams, they have a great support staff in the mental health field. They're school psychologists and mental health providers. And so we co-facilitated with them. And usually when we go into a school, we do want the counselors on hand, because those are the people that are going to get the referrals when afterwards kids are thinking, oh, I need to refer myself, or I need to talk to somebody about my friend or whatnot. So really, it's kind of a partnership. But yeah, I mean, we're available anytime for anybody that wants to take part.
And do those kinds of referrals happen? Do you hear about, you've been someplace and then you hear somebody actually went and got help? Is it that direct?
Anecdotally, I'd say yes, absolutely.
Cool.
After we go in and visit the schools, it often starts with a DVD showing to the teachers and school personnel, because the teachers spend a lot of time with the students during the day, and it's about connecting students with the resources they need. And we have heard anecdotally, in fact, right now, one of our lead volunteer, Marge McConnell on the board, is also giving a presentation on this to a parent group right now, and she often talks about how afterwards the school personnel report that more people have come to seek out help.
Oh, well, that's actually very encouraging. That's terrific. So now, you've got this program for teen depression, and then you've got this education for teachers and that. And what's the difference in them? Is it the same DVD, or what's the difference?
There's a small difference. Provides information about the DVD more at the adult level for signs to look for in students, and also the kind of help they can get, as opposed to seeing the signs in myself or in my friends. So the student DVD really focuses on 4 vignettes and student stories, really recognizing, modeling that help-seeking behavior and what it might look like. And the teacher and parent video is about knowing a little more of the background and the facts and applying that towards helping students.
And also the teen video, the vignettes, they have actors, whereas the teacher and staff DVD, it actually talks with real teachers, real parents who have dealt with mental illness with students and have sought help. So it's a little different in that way.
Do you find any reluctance on the part of teachers to make these kinds of reports? I mean, in the earlier sessions, they said, well, you know, if their grades start failing and, you know, you start seeing absences, or they're sleeping too much, or all of this kind of stuff. I mean, are teachers willing to sort of put themselves out there and say, hey, the reason your kid, you know, who suddenly went from getting an A to getting a C or a D or an F, I think that they're depressed. I think that, you know, are parents receptive to that?
I think it's the teacher's role, really, if they're not a mental health provider, to refer the student to a mental health provider, to a counselor, to a nurse, to someone who can help make that diagnosis, or help get the student and parent involved in a conversation about a way that could help them get help.
So it's not the teacher making the determination as much as it is making the referral over to a mental health person who can pursue it further.
Correct, and I also think it's less about their willingness to do that, and more about, a lot of teachers I don't think know like what to look for. You know, it's just not talked about, and I really think that our program is really important, not only for the teens to see, but also the parents and teachers, because teachers spend, you know, 8 hours a day with the students and more time than the parents do, and so they might see things that the parents might not.
Okay. Now, are there other things that other programs or other information or things you're working on that we ought to know about in our last minute or two here?
Yes. We have an after a suicide toolkit for schools.
Oh, excellent.
And this toolkit talks about all different types of things. And it has templates for, you know, sending letters to parents, letting them know that this type of death has happened in the school system. How should we memorialize the person? You know, a lot of times if a student dies from cancer or something else, there's a memorial. Well, should we do that with somebody who dies from suicide? And then there's also, you know, just working with the community, working social media. There's a whole section on social media, which is obviously with teenagers is kind of where news spreads and kind of how to handle that. So that toolkit is free to any school district that wants it. We have it. It's online, and it's, you know, definitely beneficial. So that's kind of the reactive once somebody has actually died from suicide.
Okay, so the resources are out there, and people just need to go to your website and get it. And the website is?
It is www.afsp.org, and our chapters is /NCAC for National Capital Area Chapter.
All right, well, excellent. Well, I appreciate you coming on and talking about this. It's obviously on the top of people's minds here in Fairfax County, given what's been going on with our kids over the last several years.
Well, thank you for taking on the topic.
Thank you so much.
Thank you.